department and is an incredibly valuable member of our emergency department and trauma team, very knowledgeable about all things pharmacokinetics and pharmacy related. So this is a really timely topic. Jimmy, thanks for taking time out of your day to do this. We're seeing a lot of variability in medications and traumatic brain injury, and sometimes some confusions with treating traumatic brain injury versus hypertensive emergencies and neurologic emergencies and things like that. So really pertains to pre-hospital, to folks that are transferring patients, to folks that are trying to temporize and manage traumatic brain injuries. So Jimmy, thanks very much for being here, and look forward to your talk, and hopefully we'll have lots of conversation and questions for you when you're finished. Appreciate it.
Perfect. Well, just thank you guys once again for having me on. I got a big mouth and a lot to talk about, so let's go ahead and get right to it, guys. Big thing, no disclosures for me. We're going to be talking about drugs that are cheap and conditions that are frequent. So big things we want to cover today. I'm going to hit these and a few more, but just for the sake of this, we're going to talk about some ICP control. We're going to talk about seizure prophylaxis, and then we're going to hit into some things that are a little bit more controversial along the way and hit some BP and CBP targets and really just start to look at these different guidelines, these different studies. And I'll just chime in a little bit about what I see to kind of bring all of this together. And a lot of this will just be something for you guys to kind of ponder on, and we can have a lot of discussion afterwards. So just to kind of get everyone on the same page, I know this may be recorded. People may be getting this from different areas. So again, we're gonna talk about GCS, SBP, and MAP. Just these are our fusion endpoints. We're gonna be talking about ICP, which is gonna be our pressure burden, and our CPP is gonna be a downstream cerebral perfusion. So again, every drug today really either raises MAP or impacts MAP, lowers ICP, or avoid worsening either side of this equation. So a lot of this is just looking at these base terms and these things that we say on a day-to-day basis and just simplify all of our drugs, simplify all the pharmacotherapy, and really dive into this equation of CPP equals MAP minus ICP. So the things that you guys will decide today, a few things. My buddy Marcus here is going to have a bad day. He's gonna have a really bad day, and we're gonna follow Marcus from the pre-hospital all the way through the ED into the ICU. And what we're gonna do in that time frame is kind of really hit on some key topics in SBP, oxygen, early bleeding, ICP control, seizures, and then some other components in ICU. So these are some things that you guys will do. I like to talk a lot, but I like to make this about you, the patients that you see, and the impact that you're gonna provide. So again, be with me today and answer some of these questions as we stop along with these pathways. So meet our buddy Marcus, 34-year-old male unrestrained driver. He was in a high-speed MVC, and he was ejected because he didn't wear a seatbelt. His field GCS was going to be a 6. His SBP was 84, and his SBO2 was 88. So from a trajectory standpoint, we're going to get this guy to the ED. We're going to want to control his ICP, and then we're going to look at some perfusion targets while on. And the reason I do these cases, because again, this is not necessarily just a thread. We want to connect the physiology to what you do at the bedside. I'd be remiss if I just don't hit this. Most of my attendings love to pimp their interns and people on rounds, talk about the Monroe-Kelly doctrine. So again, long story short, we got brain, blood, and CSF that share a fixed intracranial volume. And any new mass, whether that's edema, hematoma, swelling, it's going to force something out. And unfortunately, the skull is very stingy and there's no extra room. We have compliance is going to run out, and then we get to this lethal endpoint here where the ICP is going to, the raising ICP is going to drive tissue shift and transentorial herniation, and that's the endpoint of pharmacotherapy is designed to prevent. We want to prevent this from happening. I'm going to say it over and over again so we can understand that the language of all of this. CPP is going to equal MAP minus ICP. This is what I tell my trainees, again, to think about all of this, and what it means at the bedside is that we're going to be turning each knob of this. So we're going to raise the MAP, and that's going to potentially increase CPP to a degree. And then we're going to lower the ICP, which is also going to increase CPP. Both of these are going to be the point that protects the penumbra. This is going to be what my neurosurgery folks are going to be happy when we get these patients to them if we can intervene on. So of course, looking at the pathophysiology, we've got to take ourselves back and understand we have that primary injury, which can be fixed at impact. Again, this is going to be the mechanical disruption of the neural tissue. No drug or intervention is going to reverse this particular point. The secondary injury, that's where I dive in. That's where I kind of get my hands and rub them together, because this is going to be the window from days, from hours to days, in which we can treat a few different things: hypotension, hypoxia, rising ICP, fever, seizure, agitation, hyperglycemia. The possibilities are endless when it comes to the window that I can dive into from a pharmacotherapy perspective. And the goal, again, is just to really sit in this secondary window, because we can't really undo the crash, but we can prevent the next injury. So just a few key points here. Pharmacotherapy is going to be preventing that secondary hit. There's 150% higher mortality with a single pre-hospital blood pressure less than 90 episodes in TBI patients. And then when we look at about a third of severe TBI patients in that same cohort had, again, at least one hypotensive episode. So there's no neuroprotective magic bullet. We've tried many things. There's tons of studies, probably 30 or 40 I can discuss, of these magic bullets we thought we had over the last 30 years. But the job is just really just to prevent the secondary insult from what we have. So when we start preparing for talks on these, it gets kind of tricky when you start discussing the different guidelines. You got the Brain Trauma Foundation that put out their recommendations in 2016, really highlighting those severe TBI patients, hitting the SBP, ICP, and all those components. Then we have ACS really put together their combination of recommendations and really the best practices within trauma. And I'd be remiss if I didn't hit some of those. Neurocritical Care Society put together their cerebral edema guidelines as well. And the SIBICC also is going to be kind of a combined group where they have their own different tier escalation, but there's also going to be inside the ACS as well. Then we have a few major trials that we're going to hit. Again, not all of the recommendations do the same thing. They don't all agree as usual. We don't all agree. So I think this is something that when we're looking at TBI, you want to see, where's Jimmy coming from with this? It's going to be a combination of all of these sources here. All right, so we're starting in a pre-hospital. Again, protect perfusion before we get there. So again, we're going to go back to my buddy Marcus. Again, remember, he was ejected from a high-speed MVC, EMS rod, GCS was 6, SBP was 84, SpO2 88. Again, not having a good day. Again, the reason why I want to kind of highlight this is so important because he has a few things that are bad. We can say 3 of them really, but 2 are going to be really bad. Again, SBP, again, being lower than 90, that's going to be a bad day. And the SpO2 being low as well. Both of these are reversible immediately. These are things that my folks out there in the pre-hospital have access to kind of change right now. Again, we're not going to change the GCS immediately, but these are 2 reversible things we can really target. So I want to pause here, and I want you guys to help me out. Again, based on what you have here, you got a severe TBI with the field SBP of 84, SpO2 88. Which targets best protect the patient's brain right now? Is it going to be 1, SBP greater than 90, SpO2 greater than 90? Is it going to be 2, SBP greater or equal to 110, SpO2 greater than 90 with some isotonic fluids and potentially some vasopressors? Is it 3, permissive hypotension? Or is it going to be, what we're going to do 4, again, immediately give some pre-hospital hypertonic saline bolus? I'm going to switch back over here and just help me out, guys. Just throw something in the chat really quickly so I can start running my mouth and continue to the answer. Perfect. Let's see 1, let's see 2. There we go. Thank you guys, EJ. Nathaniel, thank you guys. Thank you guys. Well, let me just dive back into it because I guess if you look at this from a literature-based perspective, again, the SpO2 greater than 90 and SBP greater than 90, that's kind of some old school ATLS. And again, we understand that, and I understand why you chose that, but I try to be tricky here because the guidelines are going to really be age stratified from Brain Trauma Foundation, that the floor, particularly for these patients 15 to 49, is going to be a 110. Then oxygenation is going to be protected throughout. There's a few different recommendations for the exact SpO2, whether it's 90 or 94. But the others, again, permissive hypotension, again, it's going to be a trap. Again, if you had independent trauma, that's going to be one aspect. And then from pre-hospital, we found some data that says that may not be the best therapy to do up front. So again, we're hitting back to some of these single components, that SpO2, the SBP being less than 90, that's going to be very harmful for us. We kind of chatted about that. But the goal is looking at that wide compounds, you have an injured brain kind of loses autoregulation. And the CPP is going to track the MAP pretty passively. So decreased MAP, decreased CPP, decreased oxygen to an ischemic penumbra. So you have this double whammy of hypotension and hypoxia, which is going to really be additive harm. So we really want to get away from just that traditional SBP. And this is usually what I'm asking my team when they're in there. Hey guys, what are we targeting here? What's going to be the thing that we want to get after? Because again, I think the traditional range is going to be 90, and that's going to be the floor for one aspect. But again, with that TBI, we really have to start thinking about and ask ourselves, are we following these guidelines recommendations? If you're deviating consciously, that's one thing, but are we following these guidelines recommendations, particularly for these patients, and hitting a slightly higher goal? So looking at these Brain Trauma Foundation age stratified targets, of course, we have this age of 15 to 49, you're going to have greater than or equal to 110, from 50 to 69, greater than 100 SBP, then age greater than 70, we're going to go right back up to that 110. So you see these recommendations here, but then ACS also looks at this and kind of puts some different caveats. If ICP is not monitored, that's when they want to go ahead and use the 110 systolic, and then a MAP of greater than 80. And then SpO2, they want to go with 94, and they want to target oxygen of 80 to 100. And again, mortality risk is going to rise as SpO2 drops less than 119 in some other studies as well. So again, their goal is to kind of really push this. So for my buddy Marcus, we want to make sure we're targeting that 110. That's why I picked this age to be there, because no matter which guideline you're following, that's the recommendation that they're going to have. So we need to bump those numbers up and proceed. So thinking about this from a pre-hospital sequence is just make sure you airway, oxygen, all your ABCs is great. Hemodynamic control, and then hemodynamic support, and move fast. You got to get these people here, because again, depending on if you're rural versus urban, that kind of changes what's on the truck, but the sequence really doesn't. So we really want to focus on making sure we understand what our goals are, communicating that, and understanding what the guidelines say. So fluids, again, we start getting to drugs now. Fluids, of course, when we start thinking about hemorrhagic shock, again, blood first. Great. If you got it, use it, and making sure we're using ATLS from that standpoint. But when crystals are needed, we may start to see a shift, and we do this in practice, but I think the guidelines and data where we say use normal saline. Again, you want to avoid hypotonic solutions, and really, I love LR for non-head stuff. But when it comes to head injuries, I want a little bit more salty, because again, that LR can be slightly hypotonic. So for me, when it's talking about blood transfusions, compatibility, all these different components, I want to shift to using normal saline until we can find some more data. And if you have to use a pressor, because again, these are very intriguing times, and I've had a whole other presentation about using vasopressors in trauma and figuring out what are these exact patient populations. And I think when you get into TBIs, that's where you start to think about whether we should. It's be a conversation with the team, but figuring out if you should, norepinephrine probably is going to be that drug that we want to use. Hopefully get an A-line later on. We can start talking about ICP and CPP data, but again, focus heavily on that. Vasopressin is a little tricky. So we don't want to use that first line. Again, there's a lot of controversy with vasopressin, but I think everyone feels very comfortable using norepi. So the reason I threw that in there earlier about using hypertonic saline is that the ROC study actually looked at this. And we used to do a lot more of this. Some of my OG trauma surgeons could let me know back in the 90s, and we used to do a lot more of this before blood became really available. But we looked at it again in 2010, and this study looked at about 1,200 patients, randomized them to receive either hypertonic saline with dextran, hypertonic on its own, or normal saline. And it was stopped because it just really didn't show anything. There was no major difference across the board. Again, looking at 6 months poor neurological outcome is about 53%, 54% across the board with no statistical significance. So again, there was no meaningful difference between them. So they stopped that trial early. Then we get into something that I've chatted about before, but I want to bring back up. There's a lot of feelings when it comes to TXA. Particularly, there's a lot more feelings with TXA in patients that have TBIs. So as intracranial bleeding continues for hours after, the ongoing hemorrhage rise, ICP, risk of herniation, is going to really drop death. TXA in theory is an agent that can limit that ongoing bleeding, but Crash 3 looked at that and said, okay, let's find the data. So just a refresher for you guys, again, we have 12,000, almost 13,000 that was enrolled. Again, 9,200 of them treated within 3 hours of injury. They used a dose of 1 gram over 10 minutes, then 1 gram over 8 hours. I don't believe in that dosing strategy anymore. That's a different conversation. But again, they used 2 grams in that time frame and get it earlier. Their eligibility was again within 3 hours. Again, GCS again less than equal to 12, or intracranial bleed on CT, with their main outcome being head injury death within 28 days. Again, it's probably the largest ever TBI study ever conducted at the time of this release. So what they was able to show, guys, is that really from the overall group, there was no major difference. Again, the relative risk was 0.94, but that 95% confidence interval did exceed 1. We went to 0.0. 2, and again, they excluded GCS of 3 in fixed pupils. Again, that came to 0.89 with a 0.81. But where the benefit really turned to be was in that group that had a GCS of like 9 to 15, that mild to moderate group. And I think this gets lost, guys. I think when we talk about TXA and its utility, people just say, okay, it's not good for TBI. And I said, well, like everything, it just depends. I'm not going to recommend it to you guys if a patient comes in with a GCS of 15. I'm not going to recommend it to you guys if a patient comes in and their GCS is going to be 3 and they have nothing. But for that guy that's kind of, fighting the vent on me, it's moving around, I got to really crank up some sedation. They had a little bit more to do. Their GCS is really helping us out. Again, those are the people who I'm saying, hey, it may be reasonable. It may be reasonable to use, because again, that was where the individual had that benefit when it came to that. But also looking at the safety standpoint, there was no increase in vascular events or seizures. So I felt very comfortable saying, again, it's safe. Again, we didn't have any major issues, but the people who I thought was going to benefit, it didn't really. I would have loved to see another subgroup of people who wasn't a GCS of 3, but kind of that 5 to 8 range. But again, I didn't design the study. But what I can get from this is just saying that we may have a population that it could be useful for, and we should just have a conversation about it. So what does Crash 3 means for Marcus? Again, the big thing looking at him, he was severe. So that kind of places him in that group. I don't think it necessarily is going to be the biggest thing. I'm not going to be recommending it to you guys. If you ask for it, we can have a conversation. But again, I'm not going to be recommending it. But the thing is, it wasn't harmful. So for me, if you gave it within that time frame and looking at all the other potential aspects to it, that's where I'll be saying, hey, it's kind of a gray area. If you want to do it, great. If I don't think it's going to be harmful with that. Now, again, this is only thinking about the TBI aspect of this. This is not thinking about the polytrauma side of this and the fact that super hypertensive, all these other components getting blood. Again, we're trying to kind of isolate this as TBIs, but the water gets muddy when you start thinking about polytrauma in its aspects. So again, I realize this is super hard to really piece all this together. But if you're focusing on what am I using this drug for, if you're just thinking for the brain output of this, you may not get that. But you may, again, have a benefit from a total polytrauma aspect from the traditional crash studies. So what does this mean? Again, potential traps for Marcus is, again, make sure you hit the right blood pressure. A lot of people are saying just get the 90. Again, the guidelines don't necessarily recommend that. You got to use your isotonic fluids. Again, not hypotonic fluids. Again, that's not something that's used very often now, but again, I want to bring that up. And then you don't necessarily have to do TXA for severe TBI. There's other reasons you can use it, but I want to kind of hit these main points here from a data perspective. So let's get the patient to the ED. Let's get him here. Let's get him to me. Again, you're going to have your annoying pharmacist sitting there waiting to give drugs. I have these drugs probably drawn up already, and I'm super excited when they come in because I know the work you guys can do it. Then once you get them to the OR, I want to do my job and play around and make sure we're hitting all of these different strategies as we get to managing their secondary injury. So Marcus got to the ED. We started doing our work. The CT revealed he had a subdural, some cortical contusions, and a few early signs of cerebral edema. Neurosurgery came down and got the ICB a bolt and was able to get a reading of 26, again above that treatment threshold 22. So now we have this deal where we have competing risks that I chatted about earlier. You have your borderline hypotensive on arrival. you have this hemodynamic fragility that kind of directly constrains the osmotic therapy choice. And I'm going to tell you a little bit more why, because again, it looks like we need to do something. We're going to tube them, we're going to give them some fentanyl, we're going to start them on some sedation, and then we're going to be asking about, hey, Jimmy, go ahead and get 250 of hypertonic, or some people want to use mannitol. But let's chat a little bit more about that. So with the ICP elevated at 26, borderline hypertensive, what is going to be your first choice? So again, please indulge in my questions and tell me, is it going to be mannitol by choosing number 1? Is it going to be 2, using analgesic first sedation plus 3% hypertonic saline? Is it going to be 3, stack the mannitol, propofol, and hyperventilation at once? Or is it going to be 4, dexmedetomidine, and you're going to hold off on osmotherapy? So I'm going to switch back over to C here, what you guys are putting in. Just go ahead and put in the chat for me. I see a lot of 2s. I see a lot of 2s. There we go. Yep, it's going to be 2. Again, hypertonic saline is going to lower the ICP while also supporting blood pressure. Again, analgesic first preserves the neurological exam, get all the things you need, kind of make the decisions you want to, but that's going to be the way that I go. So one thing that I noticed, and I've been keeping track over the last couple months here, and I think people feel very comfortable when they're head of bed saying, hey, I want to intubate this patient, I want to get hypertonic ready, we're going to do propofol for after, but I'm always saying like, hey, can we give fentanyl? And when we do, let's give real doses. Always look at a patient so you can eyeball them what their weight is. You can give that to micrograms. And I would argue that most patients could get 100 mics, again, if all the other components are being taken care of. You're resuscitating, you feel very comfortable. First blood pressure, I always say fentanyl. Second blood pressure, I would say your sedation. So we've discussed this pretty frequently. Again, 22 is that range of when to treat, but the guidelines actually have some different caveats to all of this, and I will get to it. This is another slide. Long story short, ACS says you can get to, if the patient is sick, you can consider doing it with an ICP of 20 to 25 versus just a strict 22, as the neurocritical care and the Brain Trauma Foundation says. So directly into our drugs, mannitol was used quite a bit, guys, quite a bit, and it was used a lot more commonly in other shops. The dosing going to be 0.5 to 1 gram per kilo. You're going to give it over a bolus over 15 to 20 minutes. For some of my nurses, depending on how you have that set up, check your bag to make sure it's not crystallized. Keep it warm if you're using the bag. And the thing is, sometimes depending on where you're at, and you folks are from different places, sometimes the actual pump won't let you give it that fast. You have to kind of play around with that. So we make sure, one, your order set and everything, the way that you're using it, and your pump libraries are set for it to happen as quickly, and you have to make sure that's the case. Dosing, again, is going to require you to do some serum osmolarity monitoring. Again, that's could be something you want to look into, and just expect that osmotic diuretic component that can happen, which can cause significant vitamin depletion and hypotension. That's my biggest beef, guys. My biggest beef at mannitol is that it can drop your blood pressure when you have a bunch of other things going on. So you're going to intubate the patient most likely. That intratract pressure is going to potentially can drop the pressure. You don't know what your volume status is going to be as far as how they're responding to the blood. My job is to not let these drugs impact what you already have going on. So again, I want to avoid this in borderline hypotensive patients like my buddy Marcus. Hypertonic saline, tons of different ways to dose it, guys. If you look on Micromatics are up to date. They'll give you 3 to 5 cc's per kilo. Most of the time we're using 250 to 500 ml boluses. In my head, I think of it as 250. If you're concerned about it, you got some type of neurological finding on your primary or secondary, give 250 before CT, potentially give 250 after CT once you confirm the injury. That's just Jimmy vibes there. Again, when you get upstairs, you can do the bullet 23.4% hypertonic, and they're using anywhere from 30 to 40 mLs. Again, you would like to have a central line, but I've heard rumblings that may not be something that's always done. And the data, again, may be evolving when it comes to central line versus not for 23.4%. Again, simple things to look out for: serum sodium. Again, avoid rapid overcorrection. Look at your hyperchloremic acidosis. That can happen with bigger doses. But again, the focus of this presentation is like, why this drug for Marcus? Again, unlike mannitol, it's going to lower the ICP while also expanding the volume, and it's going to support, again, versus dropping it. So anytime we're looking at data with hypertonic versus mannitol, I used to get all riled up about this, but then you start looking at what's actually in the data and the numbers of patients that are in there. This study in 2003, again, you had fewer ICP episodes with hypertonic versus mannitol, again, in 20 patients. Again, another one that was an RCT that was done in 2011. Again, both agents reduced the ICP, but hypertonic had a slightly stronger and longer on a per bolus basis. And they're looking at this one in 2026. Again, it had a steeper reduction with hypertonic compared to that. So again, the numbers definitely support you have a further drop with that. And we can argue that it probably has about, again, 6 to 8, again, points reduction compared to mannitol. But the thing that I think you guys care about, that our patients care about, is going to be the outcomes. And this is where it gets kind of tricky. Mortality is not going to be statistically significant in a Cochrane that was done before. Again, in another one that was done in 2016 that didn't really show a decrease in that, and mortality as well. But again, ICP definitely did reduce. But like everything you guys are dealing with when it comes to these patients that go into the unit, there are so many factors that are in here that can impact whether a patient has mortality or not. And I think it's a really crappy, marker overall. We got to start finding some different components. But I think that the data supports clearly reduction of ICP, stronger and recurrent. And that's why a lot of the guidelines now are kind of shifting slightly towards that. So the neurocritical care cerebral edema guideline, which is really the one that is kind of focused on that, they actually support hypertonic versus other. But again, realize that the data is not phenomenal. Again, it's low quality recommendation. And then don't expect for the neurological exam to be completely different. They also recommend that mannitol remains an effective alternative when it's not appropriate. So your patient's hypernatremic, volume overloaded, you just don't have it there, or you just have that one person that says we're not using hypertonic. That's something we're going to look at. But they also recommend against pre-hospital hypertonic to improve neurological outcomes. The data just doesn't support it. So again, mannitol is not wrong, but when you look at what you're trying to do, and if you're trying to reduce ICP, hypertonic saline seems to get the job done just a little bit more effectively on paper. So how I look at it is like you look at your patient and understand your hemodynamics. You got a hypertensive patient, you can do it. Again, that makes mannitol potentially an option where you're saying, okay, it's something that we can do. For hypertonic, I really want it for my patients that you're resuscitating and you have a lower blood pressure. That's kind of the big thing for me. And for Marcus, that's why we went with hypertonic saline for him. So to getting back to that initial question, getting analgesia first, with fentanyl being the preferred agent, getting short-acting, titratable, doesn't really compromise your neurological exam beyond your sedative. And then you move on to your secondary choice. This is what your PAD guidelines, when you put in your order set in, is going to favor as well for us to be able to give a sedative after doing that. And it's going to be really based on what our guidelines support as well. Propofol, again, dosing of it can be 5 to 50 mics per kilo per minute. Again, onset's going to be really, really quick online. And then we're going to get this RASCO potentially targeting anywhere from -1 to -3. Again, our order set's a little different. Most other places do a 0 to -2. Again, I think it's fine for us to do +1 to -1. That's just what we decided. And it pairs very nicely. So when you get that fentanyl on board, you reduce the dose that you need of your prop. If you have to use Versed for refractory agitation, you can, but again, data's not great for it. Again, there's more delirium with that. Dexmedetomidine or Precex is another one that preserves neuro exam, but again, reduces propofol requirements. I throw this in here. It's rare to see it, but the pharmacist in me lets you guys know if you're using big doses for a long period of time of prop, you can get this propofol infusion syndrome. And again, signs of that: new onset metabolic acidosis, elevated lactate, rising CK, arrhythmias, and etc. Again, our order set is built for this. So again, I mention it because we have to, but just understand that. So I want to get into this next piece, and a lot of my docs that's been practicing for a while, they got to see this evolve from before we had data from the 70s saying ketamine is bad. It's bad, but maybe not for the reason that we think. The thought process was, again, back in its early times in the 70s, the FDA kind of put some precautionary statements saying that ketamine raises ICP. And I remember back when I was at Grady, I had a trauma attending, Dr. Ingram. He would argue with me every day because he just liked to argue. He's like, Jimmy, you know that ketamine raises ICP? And I was like, Dr. Ingram, now you know better than me that that's been debunked for probably 20 years now, probably longer than I've been practicing. That's been debunked. And he just wanted to mess with me to see if I knew my data. But again, the myth kind of persisted because a lot of the guidelines kind of kept that language in there. But more importantly for you guys, like, what was it? Like, what was the deal? The early studies that looked at this were in spontaneously breathing patients without any type of controlled ventilation. The problem was ketamine had a slight changes to your breathing. Again, those of you guys that are doing procedural sedation quite a bit, you understand that this is something that occurs and the CO2 builds up. Rising CO2 then dilates cerebral blood vessels, which can then increase ICP. That's going to be the real culprit. Again, uncontrolled CO2, not necessarily ketamine in itself. So you can look at any other drug or any other procedure or anything that does that. It is going to cause you to have an increase in ICP in those particular patients. And the animal data really did the same thing. We looked at pigs that we gave ketamine to, the ICP jumped from 32 to 39 with dangerous CO2 spikes. So that kind of correlated it. But when we controlled that, the ICP actually dropped. So again, the drug itself is fine. It potentially can be beneficial, but that's where all of this mess came from. And I love to talk about this because I think this happens every once in a while. So when it says it, again, the data does not support that. So I'm going to hit a couple of these. I don't want to bore you guys, but just over and over again, we had some systematic reviews that showed that there was actually a decrease in ICP in 4 of them. There's no difference in 5, and only 2 of them showed increase. And again, similar issues that they had with those particular studies. We looked at prospective data in severe TBI patients, the ones you're taking care of. Again, in normal ranges, both ketamine and propofol groups was the same. Any ICP drops, spikes were within these safe thresholds, and it raised the map without ICP. So that was something that I thought was intriguing as well. We was able to increase CPP, which is what we really care about, and it lasted a couple minutes. But just understanding that there's a twist to ketamine, and I think when you start thinking about RSI, some of these newer studies came out. You have to understand, in patients that are catecholamine depleted and not actively undergoing resuscitation, or we don't have the other components to that, you can actually see an increase in hypotension. So for me, it really depends on the patient, but I think hypotension in itself, that's going to be dangerous, and we're actively going and assessing that. But for these patients, when you're looking at ICP in itself, that's not the deal. Lots of other stuff we can look at. The pediatric data says the same thing. It is potentially a neuroprotectant, but bottom line, we shouldn't frame it as an ICP problem. The signal's more the ICP is stable, CPP may improve. The real caution is going to be hemodynamics and the things that we're monitoring in modern resuscitation. So again, for Marcus, again, something that we can utilize for him. Again, I just want to kind of go through and let people know what the data actually supports out there when it comes to it. But again, it really just depends on what else is going on outside of ketamine by itself. So the role for it, and I think if Dr. Gibbs was here, he would be big in this. You got to look at this for induction and suspected TBI. When hypotension is not a concern, it may be fine. Or if we're on vasopressors already, again, we don't have to deal with that catecholamine depletion. But most people argue that you want to switch over to etomidate for most of these. It can be an adjunct, I believe a really good one for analogous sedation in a ventilated TBI patient. And where I love to use it, and this has come up a few times, some of my docs, again, that patient's moving after intubation and they get an x-ray and they're getting ready to go to CT and they're worried about the actual CT, they're going to want to paralyze that patient. And I say, hey, let me get some ketamine, take care of the patients and then I'll go sedation, titrate themselves together. And I promise you, the same exam you want from a paralyzed patient is what you're going to get from a patient that got ketamine in their system and appropriate analogous sedation. So that's where I like to use it, because I'll hear, hey, Jimmy, go ahead and grab some VEC. And I'm like, that's tough, man. Let me get some sedation. Give me a couple minutes. And I promise you, you won't need VEC anymore, or you won't need any other drugs. So that's where I love ketamine, and that post intubation where we are hemodynamically in a good position where we have our sedation already going, and I want to provide very consistent analgo sedation, I love it there. I really love it there. That's probably the best place for me. But there's more conditions as well, painful procedures, post-intubation, sedation bridge, if they're undersedated. That's where I believe it really is a rock star and where I like to see it used more. So again, we have the SIB, ICC kind of tiered management, understanding the head of bed, analgesia first, normal capnia, treat the ICP. Then you have some things that our colleagues are doing. They get an EVD, mannitol hypertonic, kind of mild sedation escalation. Then you have the other components where you say, hey, if I failed all these, then neuromuscular blockade, again, regulating MAP for autoregulation, and then going to the barbiturates, hypothermia, and some of the other components that, again, I can't speak well to. So some traps for me in the ED when it comes to Marcus is just the reflex mannitol and the hypotensive patient. Again, that can drop you and make your job from a trauma perspective, again, worse, and a transport perspective worse. Again, chasing ICP while ignoring the CPP. Again, that's only one end of the equation. We have to kind of look at it from both sides. Routine hyperventilation, this is something that I don't necessarily see a lot of my docs do, particularly because we have we get point of cares, we got RT. Other places I've been, we've had a few cases that I've been involved in where we reviewed it, and that was some of the things that they want to kind of look at as far as the aggressive and just not revisiting the hypoventilation. Getting building stack therapies, again, simultaneous osmotherapy plus deep sedation plus paralysis plus all of that makes it hard to figure out what works, and then deep sedation without analgesia is something that can be really a tough deal for me in a trap. And then treating ketamine as a forbidden or automatically preferred. There's stream on both sides is not there. There are particular patients, particular settings where it works really well. So let's transition, guys, to prophylaxis. I got a few things here, and I'm a little bit over halfway there, so we're going to power through. So looking at Mark, because again, he's a high-risk patient. And the injury pattern, he has a cortical contusion, he has a GCS of 6, and this combination really kind of defines this early seizure risk. And it matters because, again, early post-traumatic seizure within 7 days are themselves secondary insults, and they increase cerebral metabolic demand, rises ICP, and worsen outcomes in an already vulnerable brain. And this decision really focuses us to say, does you really need this? And I think you guys do a pretty good job of that. This is something that happens commonly, but when I get consulted and I hear other pharmacists talk about their shops, again, it may be some confusion on who to do it in, if the order set is set up for it to kind of route that way, what dose you use. And that's something that I want to kind of chat about. So guys, I'm going to skip this question here because, again, we've already kind of talked about it a little bit more. I'm going to get really into the data because I'm getting behind on my time, and it's going to catch me up. So getting to the foundational data, the Timkins in 1990 looked at this, and we used phenytoin back in the early days. And what they found was with no prophylaxis, we had a 14.2% rate of early seizures compared to just 3.6%. And that was in that 7-day period of time. This is the RCT, and it did a really good job of showing a relative risk of 0.27. It was a striking reduction in this early window. That started all of this. But the thing you have to kind of catch was that there was no benefit on day 8 and onwards. There was no survival benefit, no functional benefit at 1 year. And early seizure reduction didn't necessarily always translate to long-term neurological improvement. But again, it did prevent a secondary insult. So if you can stop them from seizing in the first few days, again, then we're good to go. And the real controversy looks at this in a different sense, where we had a meta-analysis that showed that early seizure rate was going to be 0.34. Again, was going to be pretty robust and consistent, but the mortality didn't really change. The late seizures didn't change. So even when we looked at that 1990 data and we compared it to what they did in later and close to early 2000s, we didn't really see much from that. And from a practice standpoint, that means that early post-traumatic seizure only versus actually preventing the epilepsy and all the components that lead much after that. And this just summarized this very, very nicely, everything we've been saying over and over again. The early post-traumatic seizure is going to be where most of the data is. Late, there's not much there. And what prophylaxis does do versus what it doesn't. Again, it just protects that first window. Lots of slides to say the same exact thing. All right. So from a guideline perspective, everyone has kind of their particular language with it. So Brain Trauma Foundation, they actually just specifies phenytoin. This is in 2016. They released theirs, recommended to decrease it, and their evidence base is still that older study. Again, Neurocritical Care had their version, and they recommend that it may or may not be used in moderate to severe TBI. This conditional recommendation, and if it is, they actually suggest Keppra or levetiracetam over phenytoin versus fosphenytoin with those same days. ACS has a similar process where they consider prophylaxis within the first 7. Again, they specify risk features such as GCS, cortical contusions, subdural or ICH, depressed skull fracture, penetrating trauma, immediate post-traumatic seizure. So realistically, a lot of this is pointing towards, I believe that when these newer guidelines kind of get on the same page, we'll specify what that patient looks like, but it looks like these severe patients are going to have most of the benefit from it. And these are the people who are going to really benefit mostly from it. Again, low GCS, cortical or hemorrhagic contusions, and the things that we mentioned prior. So again, bringing it back to Marcus, again, Marcus was severe. Marcus had a GCS and a cortical contusion on CT, both alone by itself buys him Keppra for 7 days. But the same age, mild TBI, normal, then you can start making a decision of whether it possibly could not if you're using just the ACS definition. So again, this is where it gets kind of gray. You guys mostly just do it. And what we're doing with some of the studies we have going on right now, we're kind of holding a lot of this because again, the CTBI study is going to be done by some of my colleagues. But again, when you go to different shops and people that are not at CMC, or if you're not enrolled in those studies, these are the components that we need to look at and whether or not a patient should or should not. Long story short, it's not as simple as, again, patient comes in TBI, they get it, or where the people who actually benefits from it. This is what I mean by this mild group. Again, you have this meta-analysis that was done that looked at this, and you had a very low absolute reduction with prophylaxis in that mild to moderate group compared to those that are severe. But again, it doesn't say that it doesn't help. It just shows that the absolute benefit is tiny. Again, a number to treat of 167 to prevent one early seizure. Again, realizing that it doesn't actually lead to anything of long-term, really just another component to add on, especially if you're not using Keppra. If you're using some of these dirtier drugs, the phenytoin, it has labs, again, drug interactions and stuff, it may or may not be worth it. We talked a lot about, again, Keppra being kind of equal to phenytoin for early prophylaxis. The biggest thing is why people promote it is just no drug levels, no drug interactions, no issues from a cardiac conduction concerns, and it's preferred by brain trauma or in ACS. So Pruitt is an interesting one because we're going to talk a little bit later about some of the other ways we can use it. But again, a 1999 study actually showed that they actually had no benefit in mortality trends or harm with using valproic acid for TBI seizure prophylaxis. So stop at 7 days. Again, we looked at this. We looked to see if it works any better. Using 3 weeks versus 7 didn't show anything. So there's really no reason to extend from that. So 7 days, use your order set, and we should be good to go. So seizure traps for Marcus, again, find the right patient. He's great for this. Again, find the right drug. I think Keppra is going to be that one, and find the right duration. Those are all the things that we're thinking about when it comes to seizure prophylaxis. There's a ton of different guidelines out there, guys. Use your order set. Use what you have institutionally. Make a decision as a group of what the next steps. All right, I'm going to run through these last few once we get Marcus to the neuro ICU and chat about some things. So a big thing is figuring out whether we should push the pressure or not. Again, we've been chatting quite a bit, and I've actually had this question come to me with the team wanting to push CPP to 75 to be on the safe side, and they thought that, again, higher CPP was actually better, or does it come at a price? So guys, very quickly, put in the chat for me, if Marcus ICP is controlled and the team wants to get to a CPP of 75, again, what's your target? What's your response? Do you do number one, again, 60 to 70, don't exceed? Do you push for a CPP greater than 75? Do you drive MAP as high as is needed for maximized flow, or no real CPP target? So go ahead and put in the chat for me. And I will definitely answer the question that you guys had when we get back. All right. So again, 60 to 70 may be for the average person. Again, for the average scenario and what tools you have. Again, 60 to 70 may be the best one. Again, pushing that CPP for 75, you can do it, but it comes at a cost. And I had to go back and pull a prior study, but looking at the guidelines, this is what they recommend. And you want to avoid that upper range, potentially puts your patient at risk of getting ARDS. And I believe that this study here by Robeson and colleagues, they looked at this with targeting that cerebral blood flow greater than 70 produced better outcomes. And what they found in these patients with severe TBI was one of the first studies that looked at this. Again, close to 200 patients. They had these two different arms, greater than 70, greater than 50. They looked at neurological outcomes at 3 to 6 months. It was a really intriguing one because what they found was that in those patients that had this dose, this target of CPP of 70, they had 5 times, guys, as much ARDS. And you guys don't want to be dealing with ARDS while dealing with a TBI, while dealing with all the components that go alongside with this, again, with no major difference in a neurological outcome. So you got the increase in fivefold with no difference in neurological aspects of it. But they did see, again, some surrogate markers that made them intrigued that their cerebral ischemia fell significantly from 30 to 50. But again, things that you care about, the things that actually are harmful, again, ARDS is bad. No difference in neurological outcomes is going to be that big component. But there was some things that made them, some surrogate markers that made them intrigued. But again, this is why we probably don't push that as much. So coming back to Marcus, looking at it again, we're going to keep that CPP of 60 to 70. Again, don't really chase that. There's a few things you have to really consider. If your patient is low in trauma, you guys said, hey, he's not bleeding anymore. We've done all of our POCUS, we did our fast, we got CTs. He's fine from that standpoint. Again, once you're done giving all that, you're making titrate some norepinephrine to kind of get you closer to that goal. There's some interesting stuff out there. Again, I don't know if we're utilizing it, but some auto regulation, CPP op is another component with pressure reactive index. Again, I'm not smart enough to talk about that. I know that if someone will say, well, Jimmy, there's some different stuff out there that if you target using something a little bit more sophisticated, that's taking in consideration the CPP and the blood pressure and kind of monitor with its proprietary software, it could be something to look at in the future. But again, I'm not an expert on that. I realized that was out there, but again, that was a gotcha when I said you should never try this. I think this is one of the things that we can potentially look at. Norepinephrine is going to be a first-line vasopressor to kind of target this simply for a few reasons. Everyone knows how to use it. It's going to reliably target at alpha adrenergic constriction with predictable titration, extensive ICU, ED, pre-hospital experience. Some say to use phenylephrine as a second-line agent. I'm not a huge fan, but again, I'm just telling you what the guidelines say. And there is some caution, again, when using vasopressin as a sole vasopressor because, again, potentially can cause some cerebral vasoconstriction. Again, using it as an adjunct, which we mostly do, so I don't see that being a huge problem for you guys. And this is where I think it's the most intriguing. And I discussed it earlier, but when the brain and the bleed collides, you have this polytrauma patient that's simultaneously a TBI with ongoing torso hemorrhage. The TBI really demands a higher CPP. The hemorrhagic shock traditionally uses permissible hypotension. We have to kind of have a conversation about this. And I think that a lot of things we can look at because, again, TBI potentially could trump. And Dr. Green and a few others may say, nope, Jimmy, I want to target the blood pressure that I want. But we just have to put in consideration, again, that single blood pressure less than 90 SBP, again, carries a much higher mortality. So achieving definitive hemorrhagic control as quickly as possible, understanding what's going on. Again, that's what you guys are doing. And I think what this requires is for us to have a conversation about whether we're going to target a certain blood pressure or not. Because commonly, I don't hear these numbers. I hear MAP of 65. I hear, yeah, long MAP 65, and from a sepsis standpoint, that's cool. But I really want to kind of have a lot more conversations. Like, what are we actually targeting? Is it going to be an SPP, again, of 110 for the TBI? Are we going to go lower? Understanding we're going to sacrifice the brain? Where are we going to go with this? So I think that's a conversation that I think probably could be had a little bit more. So these are the traps for markets. Again, don't chase necessarily a CPP of 70, protect the SPP floor, titrate to the 60 to 70, and then stop, and then figure out what we can get. Just a few quick hitters. Again, VTE prophylaxis. There's a lot of information out there, but realistically, low-risk patients, again, VTE prophylaxis within 24 hours if repeat CT is stable. Moderate to higher risk non-operative TBI patients consider 24 to 48 hours. Post-crani, again, use the term as when neurosurgery tells me. The data says, again, 24 to 48 hours after surgery if post-operative CT stable, and they recommend low molecular weight heparin over unfractionated heparin for these patients with 30 milligrams Q12 as a common regimen. I'll throw this in there because it just happens quite a bit from an antithrombotic reversal standpoint. Our same deal with warfarin. I don't think we have a problem with that. Looking at the guidelines, but the biggest trend, most people are not on it, use idarucizumab. Where we get into the most conversation is the factor Xa inhibitors. Again, follow your institutional pathway. But again, the guidelines still have language in there for indexing alpha. That is off the market. Whether you like it or not, it's just off the market. And then from an anti-platelet standpoint, no routine use of platelet transfusion, again, with exposure alone, again, is going to be supported based on what you guys are going to do from a surgery standpoint. Something I want to get into a little bit more, but I'm not going to have as much time, is going to be the use of these medications for storming. So paroxysmal sympathetic hyperactivity. Again, there's a lot of components to go alongside with this, but again, some of the agents that we'll use from that is going to be propranolol. Again, clonidine, those are going to be the two big ones, and Precedex. But again, opioids, benzos, gabapentin, a few others. And then for refractory central fever, bromocriptine is something that can be used as well. Again, I won't be able to dive as deep into this, but I do want to highlight, again, so there's a lot of observational meta-analysis that suggests decreased mortality associated with using this combination of propranolol and some of the beta blockers in sympathetic storming. Again, there's a pilot study that actually showed the feasibility and safety of it. So again, with early propranolol and clonidine versus placebo and severe TBIs, again, it was feasible without major cardiac injuries. But again, this is something that my ICU colleagues can chat a lot more about. I've spent a decent amount of time talking about pain and agitation, delirium, so I won't go deep into that because I know we probably want to have a little conversation. Let's see if anything else. The last thing I'll probably leave you guys with is the potential for using amantadine. That was an interesting study that I have here. Again, it accelerated functional recovery in select patients with disorder of consciousness in 4 to 16 weeks post injury. This is kind of a rehab phase, kind of you patch them up. Component, but again, monitor for seizure threshold lowering, agitation, GI effects, and QTC injuries. So let's look at markers from beginning to end. Again, from a pre-hospital standpoint, targeting an SBP of greater than 110 or an SpO2 of 94. Blood products as hemorrhage suspected, normal saline or crystalloids. No necessarily feel hypertonic. Again, it doesn't really seem to be benefit. And TXA in these mild to moderate patients. Again, ICP control in the ED, hit them with a hypertonic, escalate as the tiered therapy. Again, ketamine can be reasonable if hypotension limits propofol. Understanding our seizure prophylaxis, again, use levetiracetam or phenytoin for 7 days and have a stop date, just use your order set. Then looking at this from an ICU perspective, making sure you have your targets from a CPP perspective, and preventing ICU complications with VT prophylaxis, PSH, fever, agitation by patterns, and really stop these therapies when the indication prevents. Here are my references, guys, and I'm going to stop talking because I can talk about this stuff all day. There's a few questions that were in there, so I'm going to take a second to pause here and look at some of these questions.
Jimmy, related to the first question that's in the chat, I put a poll on the screen for we have a few EMS folks in the audience. If you work in EMS, this poll is for you, and then the answer of that can kind of lead to the second part of the question in the chat.
Perfect.
Give about 30 seconds for folks to answer that. So the
While
question
you're
was,
going through them,
the question was,
Jimmy,
are the non-critical? Dr. Green, go ahead.
yeah, I'm sorry. I was just going to say while he's going through them, if anybody's going to be pressed for time, that was a really thorough, amazing tour de force through pharmacokinetics and pharmacology surrounding traumatic brain injury. And thanks for hitting on all of those subjects. So some good questions coming up in the chat. I'm sure there'll be some more coming by. I'll add one since I've got the mic here. I do want to hear why you disagree with the dosing of TXA in Crash 3. Crash 2, it just is overblown and doesn't apply to us very much, yet we use it like crazy. Crash 3 is an improvement, and I'd love to hear your impression of what you were referring to.
So yeah, the guy's question is basically why this dosing strategy. So I'm more on board with what our military colleagues with the 2-gram IV bolus. When I start looking at the pharmacokinetics of it, so there's two things that happen. The dosing doesn't necessarily achieve the concentrations that has been purported to actually lead to the most effective outcomes in all patients, particularly our patients in the South. When you start diving a little deeper into that, there's a huge gap between the bolus that's usually given, particularly if it's given pre-hospital.
Jimmy, you're muted, I think. We lost your sound. Still have no sound, Jimmy.
Hey, can you guys hear me?
Yes.
All right. Sorry for that. I'm going to turn this off. But long story short, the data with looking at the kinetics of TXA, the 1-gram dose, doesn't fit all of our patients. And what it comes down to is that we're often missing that second dose. So the military has done for years now and putting all of their guidelines to that 2-gram IV bolus. What it does is it helps us achieve a higher concentration for that period of time that we need for much longer, and it prevents the issue of us not ever getting that second dose. So that's why I, again, prefer for most shops, I think it's easier, and I think it's going to be more reasonable for us to give that 2-gram IV bolus up front. There's caveats to this, however. Pediatric patients, I'm not recommending giving a super big dose because they're the ones that have a higher risk of seizure. So, but for my adult patients that's usually coming to us in CMC, again, what I'm recommending in the bay is going to be the 2-gram IV bolus, and I think it's going to be easier for our team to give. It's maybe cheaper than a premix. So that's one thing I want to kind of highlight. Scott?
So another question is, and I'm going to add to the question, are there published recommendations for controlling acute hypertension in TBI patients, and more specifically, in the hemorrhaging, the traumatic head bleeds? We are concerned with that rising blood pressure, but we're not really sure how to treat it. And recently, we've been seeing a rise in the use of cardine, which I'm told is a big no-no. Why?
So we get into a weird spot. Again, from what I prepared for today, what I saw was, again, usually just greater than when it comes to those recommendations. And you start to get to a weird spot. And I can go back and double check to see if there's an upper range. But traditionally, that's not what we see. I'm intrigued with the fact of you're playing with the auto regulation. I'm just going off of what I'm thinking here when it comes to cardine, because it does a really cool job of actually when cardine hits acidic, again, blood, it actually gets trapped into the brain and causes pretty a prolonged vasodilation, which is great in some cases. But again, I'm not certain.
We lost your mic again, Jimmy.
Can you guys hear me now?
Yes.
Perfect. Again, sorry about that. Again, uncertain of the upper range based off the guidelines, and I will get back to you guys about carding just from the sake of time standpoint. So I'll look back into that, and I will respond to Scott, and he can kind of forward it to that individual. See, any other quick questions? I know I'm getting ready to run out of time.
One, going back to one of the original questions about the hypertonic versus mannitol, the majority of the respondents said they don't carry either. Like one or two said they do carry hypertonic saline, but the specific question with that was that you had said that you wanted to see more saline, but does that affect the pH more? Normal saline with a pH of 5.5 versus LR at 6.5.
With multiple doses. So what I believe is, again, if I'm giving saline the whole hospitalization and I'm giving a ton of it, again, that's where we start to see that hypochloremic acidosis pile up. However, there's twofold. We probably shouldn't be giving, again, in these patients that are potentially hypotensive, we probably shouldn't be giving that much saline to begin with and trying to get them blood as much as possible, and again, or just kind of restricting it to about 1,500, going back to the ATLS component of it. But if you're giving 4 or 5 liters, yeah, that is something to be considerate of. But I would argue that, and I'm hoping that in most shops, once you get them dropped off, if you're a liter and a half in, that's not going to be a significant amount compared to when we start dumping a bunch of blood and stuff in them as well. So again, I would prefer to not have the issue with my hypotonic perspective, even the small risk of it with LR. But again, if that's all you have, that's one thing. But most shops, again, most from what I'm seeing, should have saline to begin with, and then we can get loaded up with hypertonic once they get to the ED.
Great, thank you. There's another question briefly of what would you be the max amount of normal saline that you would want to see in those patients?
Again, at that point, I'm just going to say what ATLS is going to recommend. Again, the upwards of, again, I think 2 liters would be the maximum, 1,500. But realistically, my physician should be aware if you're giving that much volume without blood in a patient that's sick. So again, that would be the one thing that we should probably have a conversation about, put in the protocols. But 1,500, the two liters, again, depending on which particular guideline you're using, is where we should say, hey, we should start having a conversation about what else we should add on.
I agree. Once you start getting more than that, something's not right. So that's definitely be a max end on that one, or at least a pause to consult with somebody who's a lot smarter than I am.
Well, thank you guys. We're getting low on time. I would love to answer more of your questions. You guys can send me an email. I'm jimmy.pruitt@advocatehealth.com. So again, you can definitely reach out to me from that aspect. I'm probably the easiest person to get in contact with from a social media perspective as well. So you can always reach out from that perspective. But really appreciate you guys having me on. Excited to work with you guys. If you come again, it'll be an honor to kind of, again, continue to answer more of these questions and work with you guys.
Great. Thank you so much, Jimmy. And I'm going to put the evaluation in the chat box so you can access that later on also. Appreciate everybody.